Right. Well, thank you so much, everyone, for joining our webinar, Novel Surgical and Non-Surgical Approaches for Pancreas Cancer. I'm so excited today to partner with Miami Cancer Institute, who is also our sponsor for our Purple Stride Miami and our Purple Stride Broward Palm Beach events this year, which I'll talk a little bit more about later. I am very excited to introduce our three special guest speakers. Dr. Michael Chung, radiation oncologist, Dr. Dominic Asbin, pancreas surgeon, and Dr. Antonio Ucar, medical oncologist at the Miami Cancer Institute. And we will have a nice big section at the end of their presentations for questions, so please hold off until then, but please utilize the chat function to enter your questions in as we go along, and we will try to answer as many as we can. And without further ado, I think I will pass it over to our first speaker, Dr. Asbin.
Thank you very much, Addie. Let me start by sharing my screen. Can you guys see my screen at all? No.
Not yet. Sometimes it takes a moment. There we go. Wonderful.
So pleasure to be here today. Thank you very much for the opportunity to participate. I'll be speaking on behalf of the surgeons in terms of what novel advances we've made over the past few decades, really, in treatment of pancreatic cancer from a surgical standpoint. So I have no disclosures. And just as a brief background, these lines that you see are the death rates from different types of cancers over the past 80 years. As you can see, lung and bronchial cancer, even though there was a very kind of sharp increase in the 80s, started dropping off in the 2000s and onwards. Colorectal cancer has had a steady decline over the past 70 years. But pancreatic cancer, unfortunately, has had almost an ongoing steady climb. As you can see, over the last few years, it's gotten a little bit better, but it's still not doing as well as the other types of cancers. And the reason I mention this is because even though we have had some very significant advances, and you'll hear from the other speakers as to how important they have been, it's still difficult to find things that can really make a big dent in this terrible disease. And so what we realize is that when you have a disease that is this bad, where the prognosis is this poor, any small advances can have a big impact. And so anything, especially that improves survival or quality of life, is considered a significant change. And that's a lot of what we've seen with surgical advances. The main surgical advance, and as far as pancreatic cancer goes, has to do with the advent of minimally invasive pancreatic surgery. And this is minimally invasive surgery in general, also called laparoscopic surgery, but it includes robotic surgery as well as the two most common approaches to surgery from a minimally invasive standpoint. For those of you that aren't familiar, it basically means that instead of doing a long cut, which was the traditional standard way of doing operations, the surgeon does multiple small cuts. You see here on the left, this diagram shows those blue things are surgical ports or trocars. And so small cuts are made, the belly is insufflated with carbon dioxide, and then through those ports, instruments are placed. One of them is the camera, the one you see on the right, and the other ones are instruments that allow us to do the procedure through much smaller incisions. The robotic surgery is similar in the sense that you have small cuts and you have trocars placed, but the instruments we use are not directly held by us. They're these machines that we control. It's not a robot in the true sense of the word where it's fully independent. It's not independent at all. Actually, we are the ones that control the instruments, but it does allow for certain flexibilities in some maneuvers. The big difference, as I mentioned, is the ability to perform a surgery through small incisions and not through these traditional large open ones. Now, just quick anatomical background. I hope this doesn't gross anybody out, but if we were to look at where the pancreas sits in the belly, going from kind of the most superficial aspect, first you see this. All this yellow stuff is kind of fat. This is the stomach up here, intestines below. If we go kind of one layer below, we see that you have the stomach lifted up, and then cutting through the fat, we have this area back here. It's called the lesser sac. And way back here in the back, within the fatty tissue that's in the back, you get this beautiful organ here, which is the pancreas. Now, the pancreas is tucked away in this area, kind of hard to get to. And if we kind of explore a little more of its relationships to the anatomic structures, we see all these big important vessels here. The blue is an important vein. The red is an important artery. These supply the majority of your intestines. Back here, you get these vessels go into the liver, which is not shown here. The aorta is at the top. This is the first part of the intestine. The kidneys are on the sides. So basically, some of the most important structures in your body are all situated in this area. I like to call this the surgical soul, just because of the importance of all these structures in one concentrated area. So needless to say, any surgical intervention, especially a minimally invasive one, is at first challenging until we figured out how to kind of get in here. But, you know, the first really strong trends in laparoscopic surgery started in the mid 80s. And by the 2000s, there were already people performing pancreatic resections. A decade or two later, we already started seeing some very important trials. Now, don't worry about reading all this. This is just to show some of those most important trials that have compared the data or the outcomes of surgery between open and laparoscopic surgery. Some of these also include robotic surgical procedures. And for those of you that are interested, the ones on the left involve a distal pancreatectomy, and the ones on the right involved a pancreaticoduodenectomy, or the Whipple procedure. Now I'm going to take one slide back. The distal pancreatectomy is surgeries to this part of the pancreas, or this part, which is in a lot of ways an easier operation because you don't have all these important structures. The Whipple procedure, as a lot of you are probably familiar with, involves surgery right here, which is taking out this part, which is the head of the pancreas. And you always have to take out the intestine as well and some of these important arteries. This procedure is considered more technically demanding, but as you guys can see from this slide here, studies have shown benefits to laparoscopic or robotic surgery for both the Whipple and the distal pancreatectomy. Now, I want to highlighting some of these benefits, the things that have been most statistically significant. So after we analyze the data and we see what really makes a difference, has to do with patients' recovery. There tends to be a decreased time to recovery, to functional recovery, meaning they can move around and continue with their life. There tends to be less time spent in the hospital. And this is, for the most part, without any increase in complications or in deaths after surgery, which of course is equally important. And also the quality of the surgery from a cancer standpoint, meaning how many lymph nodes we can get out, how many times you can do an operation getting the entire tumor out, meaning an R0 resection is what it stands for. Also, no difference in any of that. So because of that, a lot of centers are moving towards doing more and more minimally invasive surgery. Robotic Whipples or distal pancreatectomies have caught on in many parts of the country, as well as laparoscopic surgery is very well established for its benefits. Now, beyond just that, there was an important conference in 2020 that we had here in Miami, where experts from multiple different societies, so a lot of different groups, surgical groups throughout the world from 20 different countries came together, and they analyzed all the data, including those studies that I showed you. And they said, okay, what can we say as a recommendation about these things? And some of the important ones, basically highlighting that the MI is minimally invasive distal pancreatectomy. So surgery for, as I mentioned, the more easier part for benign and low-grade malignant tumors. So tumors that aren't super aggressive. Those should basically definitely be done laparoscopic instead of open. So these are pretty strong recommendations for people saying we should actually move away from open surgery for these procedures. The outcomes, as I mentioned, shorter hospital stay, less blood loss, and no difference in the complication rates between open and laparoscopic. So there are some benefits to that. There's also better quality of life after surgery, and based on what these studies have shown. Now, for more aggressive tumors like pancreatic cancer, it appears to be feasible and equally safe and efficient in experienced hands. So this is, an important thing to mention. There's still more data that needs to come out. The society conference was done before one of the big studies came out for Whipples, but regardless, the idea is that there's nothing to tell us we can't move forward, and if anything, things look like they might actually even be better. And it's basically an important thing to mention is that there's no contraindications really, meaning there's no absolute reason why you can never do these surgeries on patients. However, even though this is something, it's a tool that we love to use as surgeons, and this is something that we're very excited about, there are always times in which the surgeon decides, look, it might be better to do this open. open meaning a more traditional surgery. So in this slide, and I got this from a website, whipplewarriors.com. I like this slide a lot because it shows some of the different scars that sometimes patients have after these Whipples. You can see this is a midline incision, kind of a big open. This is called chevron, which is under the ribs, which is, I would say, done maybe even less than this midline one. And then these are the laparoscopic incisions, a little fresher incisions in terms of the color, but you can tell they're much tinier. Regardless of which of these a patient gets, if the surgeon decides that under their judgment, it's better for them to get this incision or this incision, then that's okay. We have to be flexible. As much as we like using our new tools and techniques, we always have to be flexible and do what's best for the patient. So there are some patients that I myself will operate on open, without a doubt, and other patients where we'll say, let's go laparoscopic. So the bottom line is, as surgeons, we're very excited about how we've been able to push the boundary and continue to help patients by making the surgery less traumatic. And you know, we're very excited about seeing what comes next. Thank you, guys. I'll be happy to answer some questions.
Wonderful. Thank you. I think we'll save them till the end. So everyone, if you can just kind of take a minute to reflect on that wonderful presentation. And I saw some questions already come through. So again, I'll save those. So thank you so much, Dr. Aspin.
No
It's just
problem.
exciting to see, you know, even just what's come about in the last couple of years. So thank you for sharing. I think we will go on now to Dr. Ukar, if you want to share your screen.
All right.
Wonderful. Looks like it's up. All right, thank you.
Can you see my screen there?
Yes, you're all set. Looks great.
Just give me a second. Okay. Okay, so today I'm going to talk about the non-surgical approaches for pancreatic cancer. And I think that one of the most important changes in the treatment of pancreatic cancer from the medical oncology point of view has been the use of neoadjuvant chemotherapy or neoadjuvant treatments, which basically means that you're administering the chemotherapy ahead of the surgical procedure. The advantages of neoadjuvant chemotherapy are, of course, tumor downstaging, because by reducing the size of the tumor, you can potentially achieve higher rates of resectability, and you have less microscopic disease that you are going to be leaving behind. If you leave microscopic disease behind, then that defeats the purpose of the surgery. You also can reduce dose adjustments compared to adjuvant therapy, because many times with these very complicated surgical procedures, patients take some time to recover, and the chemotherapy might be too much for some of them, and you have to reduce the doses. But if you give the chemotherapy ahead of the surgical procedure, then you circumvent this problem. And the other advantage is that you can actually do in vivo testing of response, because if you give the chemotherapy before removing the tumor, you can actually see if the tumor is shrinking. Once you remove the tumor, you are giving the chemotherapy, in a sense, blindly. You're just hoping that the chemotherapy will get rid of any residual cancer cells. With regards to the resection categories for pancreatic cancer, we talk about resectable, when the tumor can be operated on immediately. Borderline resectable has to do with the relationship of the tumor with all the blood vessels that Dr. Aspin showed in the diagram before. And sometimes the tumor is too close to the blood vessels, and by giving chemotherapy, you can actually reduce the size of the tumor, move it away from the blood vessels, and facilitate the surgery. A non-resectable is when the tumor is wrapping around certain blood vessels, and not even with chemotherapy or radiation therapy, you are able to make the tumor operable. The two most common regimens that we use for neoadjuvant therapy are FOLFIRINOX or modified FOLFIRINOX, which is a combination of 3 different chemotherapy drugs and gemcitabine with nab-paclitaxel, also called Abraxane. And in this study, patients were compared with basically a group of patients received 3 months of FOLFIRINOX, the other group of patients 3 months of gemcitabine and nab-paclitaxel surgery, and then 3 more months of chemotherapy. And the results were equivalent. At 2 years, the overall survival was almost identical, 47 versus 48%. So this, rather than being something disappointing for us, gave us some confidence that both regimens are essentially equally effective, and we shouldn't get upset if a patient cannot tolerate one of the regimens, because perhaps there's another regimen that is a better fit for them. And these are some ongoing trials of interest in the neoadjuvant and adjuvant settings. These are national studies. The first one, for example, is comparing, it's actually testing the use of Gemzar and nab-paclitaxel with this anti-connected tissue growth factor antibody called pamrevlumab for unresectable pancreatic cancer. And there are some there is some indication that you can convert unresectable to resectable by using this combination, something that we haven't seen so far. The next study is comparing perioperative FOLFIRINOX versus post-operative FOLFIRINOX. And the last one is testing the use of chemotherapy with FOLFIRINOX with or without radiation therapy. Then I thought that for us, it was relevant to talk about some of the clinical trials that we're collaborating with from the medical oncology point of view. The first trial is a study for unresectable pancreatic cancer. So these are tumors that cannot be operated on because of their relationship with other organs and blood vessels, but they haven't metastasized either, so they haven't traveled to other organs. And that's very important. Metastatic disease doesn't qualify for this study. And it's a collaboration of interventional radiology, radiation oncology, and medical oncology. In this trial, the hypothesis is that pancreatic cancer is hypovascular. So blood vessels don't really feed the tumor the same as other tumors. For example, in the upper right-hand corner, we see a liver tumor, and you see that there are many blood vessels reaching the tumor. Below that one, you have a pancreatic tumor, and the blood vessels don't appear to be reaching the tumor itself. So the solution for these hypovascular tumors that we call the ones that do not have significant blood feeding is to try to use chemotherapy by diffusion through the arterial wall. And by using this technique, we have found out that patients appear to have a better response, as the tumors with high blood perfusion have a higher survival than the tumors that have lower perfusion. And in this study, in the experimental arm, patients have a catheter inserted through the groin into the artery that sits next to the tumor. And you increase the pressure to allow for the chemotherapy to diffuse out of the artery into the tumor itself. And this is the device that is being used. It's a catheter with a balloon in the distal end and also the proximal end. And then you increase the pressure and allow the chemotherapy to diffuse out of the blood vessel with 99% effectiveness. The schema for the study is basically to administer 2 months of Gemzar and Abraxane, followed by radiation therapy, 1 extra month of Gemzar and Abraxane. Then patients are randomized or assigned randomly to the study arm, which is the catheter, the intraarterial chemotherapy for 4 months versus continuing chemotherapy, conventional chemotherapy with Gemzar and Abraxane. and later on patients go into a maintenance phase. The next trial that we have is a trial to assess the combination of zolbetuximab and paclitaxel with gemcitabine for first-line treatment of patients with Claudin 18.2 positive metastatic pancreatic adenocarcinoma. So this is for patients that have cancer outside of the pancreas in other organs, but they have to express the Claudin 18.2 in order to be eligible for this trial. About 25% of the patients with metastatic pancreatic cancer express Claudin 18.2 at a level that allows to participate in the study. The study drugs that we use along with the chemotherapy is zolbetuximab, which is a monoclonal antibody against Claudin 18.2. Claudin 18.2 is a biomarker located in the outer cell membrane of the cancer cell, so it is accessible for targeted therapies. And targeting Claudin 18.2 disrupts the cancer cell membrane permeability, facilitating cell death. We've seen very good results so far with this study, but although this is not official, this is somewhat empirical. But we've had a couple of patients with very good outcomes. And finally, this is a study that we don't have open yet, but soon to be open is a phase 1 study of another chemotherapy combination, FOLFIRINOX, with a monoclonal antibody called AV380 for patients, again, with metastatic pancreatic adenocarcinoma. And basically, this antibody that we're testing targets GDF15, which is basically a factor that stimulates cachexia. And cachexia basically is muscle wasting that is commonly associated with cancer. And 50% of patients with cancer will suffer from cachexia, which is a debilitating situation. 30% of patients will die from cachexia. And targeting the GDF15 with the AV380, which is an immunoglobulin, a monoclonal antibody, has shown preliminary good results in animal studies. Of course, we're testing this hypothesis now in humans, and it doesn't always extrapolate, but we are optimistic about this study. I think this is the end of my presentation. Thank you very much.
Wow, thank you so much, Dr. Ucar. I have not had the pleasure of hearing that presentation yet from you, and I think that there's so much trepidation still around clinical trials and, of course, around chemotherapy. And I think just one of my biggest takeaways from you is how important it is. I've had a couple friends recently who have been going through some surgery and had chemotherapy before, and I didn't think about how then it would affect their aftercare and their after chemotherapy as well. So really important points, and so exciting to see all the different clinical trials and all the things that are being done, and just to hear your enthusiasm about some of the results that aren't even really published yet that are so promising. So that got me really excited. And now we will go ahead and move on. If you want to stop sharing your screen, Dr. Ucar, we can then go on to Dr. Chung's presentation.
Hi, good afternoon. Hopefully you can see my slides.
Sorry, yes, you are up. You're fast. Thank you.
Hi, good afternoon, everyone. I'm Dr. Michael Chung. I'm a GI specialized radiation oncologist here at MCI and work very closely with Dr. Ucar and Dr. Asbin as part of our specialized multidisciplinary pancreas program. So with that being said, what I'm hoping to share with you today, or hoping to give you a better sense of, is how far we've come from a radiation therapy standpoint in the management of pancreas cancer. A lot of what guides radiation therapy now in the postoperative setting, or the preoperative setting, or the definitive setting, meaning if surgery is not an option and we're using radiation as a local treatment instead of surgery, a lot of that is based on data that is very old and using outdated radiation techniques. And so we're very proud and very excited that we do offer one of the most state-of-the-art, if not the most state-of-the-art technology that is especially well suited and really offers significant benefit to pancreas cancer patients who do not have surgery as an option, which is unfortunately the majority of patients who are diagnosed with pancreas cancer. So I do have some disclosures here. So to give you some context, this is what radiation therapy actually looked like when it was first developed, believe it or not. So this obviously was many years ago, but the ability to shape radiation dose and to carve out doses out of tissues where the tumor was not involved, was very, very poor at the time. This is sort of what some of that looked like. And internally, this is what the radiation dose looked like. So you can see here, there are CT scans, and where there are colors, the color represents different amounts of radiation, okay? And so the orange or the red color represents a relatively high dose of radiation. The bluer, the greener colors represent low doses of radiation. And so the red circle in the middle of the scan represents a pancreas tumor. And you can see with older forms of radiation, there was, the tumor itself was being treated, and there's the color or the dose that overlays the tumor, but there's a lot of collateral damage. And you can see that the majority of the intestines and a lot of the kidney and the skin would get a lot of radiation dose. And this simply was not safe now in retrospect in terms of, it caused a lot of side effects, but also at the same time limited how much radiation could be safely given to these tumors. And that was a major limiting factor. If we fast forward to today with standard radiation machines, you can see that the colors are much more confined. And so this is what would be delivered with what's called standard, or what's called SBRT, or stereotactic body radiation therapy. So we can shape the X-ray beams very, very nicely now. But there still is excess radiation dose delivered to the stomach and to the intestines nearby, in part because of some important limitations of even the most state-of-the-art delivery machines that use something called CT guidance, and I'll explain what that means. But what do the data show for unresectable patients who get radiation therapy, at least historically? There's a very important and well-known study that randomized patients who had unresectable locally advanced pancreas cancers to get either chemotherapy alone or chemotherapy followed by standard dose radiation. And what that trial showed was, while local control was better with even modest doses of radiation, the survival long-term was not significantly different. And you can see the curves here essentially overlap. I would remember the 2-year survival number of 20%. We'll come back to that. But that really has been repeated over many, many trials in terms of what the survival rate, at least at a 2-year time point, is with chemotherapy alone or with the addition of standard non-ablative radiation, we would call it. Why does any of this matter? So if you look at published autopsy studies of patients with pancreas cancer, looking specifically at why patients die of their pancreas cancer, it's interesting. So the majority of pancreas cancer patients ultimately and unfortunately develop distant metastatic disease, so tumors involving the liver or the lung or the peritoneum, and that can cause, that can lead to death. But even in the presence of distant metastases, up to about 30% or so of patients in this study from Johns Hopkins actually died of effects of local progression of tumor, and that could be from bleeding or obstruction or other problems. But it's an important number to remember, so that in some patients, at least those who are at most highest risk for complications from local progression, potentially survival could be impacted by improving local control. And so therein lies the important concept that we have historically been only able to deliver moderate doses, what we would call non-ablative doses of radiation to tumors in the pancreas, in part because of how close the stomach and the intestines lie to these tumors. Although this is a recent publication showing that if we are able to deliver a higher dose to tumors, that can prolong and improve long-term local control. So the question really is, how do we do so safely? And this is just to drive home the point. This is an example of what ulceration looks like in the stomach, and really, bleeding and other type of bowel or stomach complications can certainly happen if we're not careful when trying to deliver higher doses of radiation. So what are obstacles to delivering what we call ablative or high dose radiation that has the potential or the intent to potentially eradicate the tumor in its entirety? So one is that most standard radiation machines use CT scans to position patients and to image them prior to treatment. Although CT scan image quality is not great, and I'll show you some examples of that. It's a little bit fuzzy, and you'll see that. There is not an ability to image during the treatment delivery itself. We're able to get CT scans prior to the patient being treated, but not actually during treatment. So there's uncertainty there, especially as tumors can move and do move as patients breathe. So believe it or not, tumors in the pancreas can move upwards of 2 centimeters or more, typically in up and down motion. So delivering pinpoint radiation to these tumors becomes very challenging as a result. And typically radiation therapy is delivered over multiple days, and sometimes in some situations over multiple weeks. And the internal anatomy, especially the bowel and the stomach, their positions will change on a daily basis, if not on a minute to hour basis. So that is something that is not able to be accounted for on a day-to-day basis with standard radiation treatment. You basically give the same carbon copy dose distribution each day you come in for treatment, and we're not able to account for those changes. So to give you a sense of what the images look like with standard radiation, patients who get radiation therapy all have what's called the simulation CT scan for mapping purposes. And that scan quality actually looks pretty good. This is acquired on a typical CT scanner, but the CT scan that you see on the right is acquired from the treatment machine itself. So the quality of that scan is not as good as a dedicated CT scanner. So if you ask me where the intestine was versus the pancreas tumor versus something else on the scan on the right, I'd be lying if I told you I could tell you exactly where those intersected. This is sort of what it looks like when patients are treated with standard radiation in terms of the imaging or what we see on the console during the treatment. There is not a CT scan that's required during treatment. So all we really see is, there's a camera looking at the patient lying on the treatment machine, and we make sure that they, are doing okay, but there's actually no imaging during the treatment itself. So obviously that leads to a lot of uncertainty. The exciting or one of the exciting aspects of our radiation therapy program here, which we offer proton therapy and CyberKnife, gamma knife, basically you name it, we offer it here. For pancreas cancer patients, from my perspective, those who have unresectable tumors are best treated with something called the Meridian LINAC. And this is a program, and we were the second in the country to start treating with this in 2018. It's still a relatively scarce resource in terms of the number of centers offering this particular treatment. And you can see what that looks like as of today, with much of the country in most states not offering this technology whatsoever. Why is this so unique? So this is a treatment that uses MRI instead of CT scan to image patients. And it's essentially a hybrid MRI scanner with a state-of-the-art X-ray machine all built into one. So we're able to image patients with MRI and treat them with a state-of-the-art X-ray treatment. MRI scans are acquired for diagnostic purposes for pancreas cancer, so it only makes sense that we would get them, if we could, for treatment purposes. And we prefer MRI scans over CTs for the reasons you see here, and that the soft tissue image quality is substantially better. And I don't think I need to convince you of that. You can see the picture on the right versus the picture on the left, where I can clearly see the pancreas tumor versus the intestine, versus on the left, it takes a little bit of imagination. So not only is the image quality better with MRI, we can image throughout the entire time treatment is being delivered, unlike with standard radiation machines. And what you see here, outlined in green or yellow, I can't really tell, but you can see that it's out. There's an area outline, which is essentially the tumor, and you can see this in multiple planes throughout the entire treatment. So not only can we see the tumor moving, and you can see it moves quite a bit as the patient breathes, and you can imagine what is happening on a standard radiation machine if you're not able to image and appreciate this. But not only can we image with this amazing MRI scan during treatment, the machine automatically will turn off and turn on based on the position of the tumor. So if you see in the bottom middle, you see it says beam on and beam off, and that's entirely automated based on the position of the tumor within a certain position. So as the tumor moves out of that blue area, the machine will turn off, and when it comes back in, it will automatically turn on. So the precision of this is unparalleled in terms of compared to any other radiation approach. And then last but not least, why this is so incredible is that the anatomy every day will change, as I mentioned before. So we will plan radiation to be delivered to a particular place, assuming the anatomy is in that place. But on day one versus day two, maybe the anatomy moves. Maybe the stomach is more full one day than another. And being able to account for that and adapt the treatment is incredibly important to ensure that the dose goes to where it needs to go and doesn't go where it doesn't need to go. And this happens each day before treatment. And this is the first time really in history that radiation therapy or radiation oncologists have been able to do something like this. So we really personalize and adapt treatment each day. So what does this all get us to? So one is that we're able to deliver substantially higher doses of radiation to an ablative range. These are doses that potentially can eradicate tumors or are much more likely to do so than with standard radiation doses. I'm proud that we're one of the worldwide leaders in publishing data. In fact, have the largest experience of ablative MR-guided radiation that exists today for unresectable pancreas cancers. And the outcomes really are staggering. So these were data from our institution that I presented last year at a European meeting. I've told you to remember that 20% number from before in terms of 2-year survival. The outcomes that we've seen at our institution have been upwards of 50%, which are actually on the level of what you'd expect from surgical resection. We combined our data with several other institutions internationally, presented at our main radiation meeting last year, almost 150 patients treated to this very, very high dose on this Meridian device. I won't spend too much time on the numbers, but again, that survival number at 2 years, if you see at the bottom, of around 50% was replicated in this study as well. And I think the exciting part obviously is that patients seem to be living longer, but quality of life obviously is critical and important. And it's really amazing to me to see today that side effects are very, very rare. And in fact, quality of life does not appear to be impacted really at all as a result of this. And it's really because of the advanced technology that we're ensuring that high dose is not going into the stomach, into the intestine. This was a patient that I treated a few years ago whose daughter sent me an email just out of the blue. The patient was having severe pain before, but just shortly after her pain substantially improved, she was able to go to Hawaii and hike and do all of these other incredible things. This was, I think, just a week after her radiation therapy. So really, I think a very common experience to share with you. This is sort of hot off the press at our main the International Radiation Oncology meeting that just wrapped up in San Antonio this week. These are the first prospective international phase 2 data of ablative radiation therapy delivered with the Meridian device in 5 days. And I forgot to mention that before. This is all done as an outpatient over 5 consecutive days. And I'm one of the national PIs for the trial. And this is a trial that looked to just confirm prospectively that we're not causing patients harm and causing major toxicities. I won't spend time on the demographics here, but the primary endpoint, which was really amazing for us to see, was looking at grade 3 or higher, meaning severe toxicity that was definitely related to SMART, or the type of radiation I just described to you, within 90 days of treatment. And believe it or not, that number was actually 0%, and that even surprised me. But this number, I think, is a really strong signal that this is a safe treatment. We are, and I'm the lead international PI for a trial called the LAP-ABLATE trial. That is the successor trial to the trial I just presented previously, that will start enrolling next year, and we're the lead institution for that. That will randomize patients who have unresectable pancreas cancers without progression after initial FOLFIRINOX or gemcitabine Abraxane to either receiving this type of high-dose ablative radiation versus continued chemotherapy alone. And this is a trial that's designed to show a difference in 2-year overall survival. And hoping it replicates the retrospective data that we've seen. You can see the PI team on the right. Some may recognize some of these names, especially Eileen O'Reilly, who's a very well-known medical oncologist at Memorial Sloan Kettering, in addition to many other world leaders in the pancreas space. So last but not least, I think the Meridian patient experience is very important to highlight. It's an outpatient treatment. It's completely non-invasive. There's no key contrast or IVs or anything like that. There's no anesthesia, no implanted fiducial markers. Typically 5 or fewer days and little to no downtime. Most patients will go to work the same day or do whatever they need to do or whatever they normally do. So in conclusion, I think we can now say with the prospective data that I just shared that this is a safe treatment delivering such high dose, in fact, 2 to 3 times higher than you would deliver it safely on a standard radiation machine. The implications on survival are obviously very exciting with no apparent detriment to quality of life. Most patients have minimal side effects, and honestly, many patients don't have any. We are proud to be a world leader in this, and I think the biggest thing is that it's offering hope to many, many patients. And seeing long-term survivors in my follow-up clinic now is fortunately becoming much more common. So with that, I thank you for your attention.
Thank you, Dr. Chung. That was a beautiful way to end, hearing the success stories and just, seeing how connected you are to your patients and their quality of life. And I have had the pleasure of seeing some of that presentation in the past, so it was really nice to see it again. It got me just as excited, if not more, hearing about all the different therapies that are available at Miami Cancer Institute, Gamma Knife, proton therapy, and Meridian, etc. So just the three of you together as a team is mind-blowing and really exciting to see the care that you offer. I think we do have a little time for questions, and we have lots of great questions that came in. So I'm going to share my screen real quick here again, and let's try to get to as many as we can. All right. So first, let's go ahead and start with, and the three of you can jump in and answer anyone that you that makes sense for you to answer. So we'll start with, what are the risk factors for pancreatic cancer, and can it be genetic?
Well, risk factors for pancreatic cancer include smoking. That's a big one. Also sedentary lifestyle, obesity, fatty pancreas, the same as we call fatty liver. So excessive fat in the pancreas can lead to pancreatic cancer, chronic pancreatitis, certain cysts in the pancreas like IPMM, especially when it's in one of the major ducts in the pancreas, can be a risk factor for pancreatic cancer. Family history, and yes, there are hereditary syndromes, mutations of BRCA1 and 2, especially BRCA2 can increase the risk of pancreatic cancer. Lynch syndrome can also increase the risk of pancreatic cancer. Mutations of PALB2, another gene, can lead to pancreatic cancer.
Wonderful. Thank you so much, Dr. Ukar.
I just want to add to that quickly. There, there are emerging guidelines and kind of conversations about screening for patients that are at higher risk. Not, necessarily anyone that is obese, for example, but even though that is a risk factor, as is smoking, especially if you have a significantly high risk, like one of these known genetic mutations, talk to your primary care doctor or reach out to an oncologist like Dr. Ukar, because there are ways sometimes to screen for pancreatic cancer, which is usually not done if you have a normal level of risk.
Thank you so much, Dr. Asbin, and you can also reach out to patient services to get more advice about genetic testing in your area and genetic screening. So thank you for that addition. And then I wanted to move on to asking a question about chemo. So probably for Dr. Ukar, how long does the typical patient receive chemo? There was an instance with someone continuing with 2 times a month and just it's going well, but just wondering, does it go on forever?
Yeah, this is a difficult question to ask and a difficult concept to grasp. So it is different when the patient has metastatic disease versus when the patient is being treated with curative intent. So for example, all the talk that I had about neoadjuvant and adjuvant chemotherapy, that is a set number of chemotherapy cycles, usually 6 months of chemotherapy divided before and after surgery. So if the patient has no chemotherapy before surgery, then 6 months post-surgery. If the patient has 3 months, then 3 additional months post-surgery to try to get to 6 months. But when the patient has metastatic disease or disease that you can actually see in the scans, it is difficult to say, well, let's stop the chemotherapy and see what happens, because you kind of have an idea of what will happen if you still see metastatic disease and you don't treat the patient. So typically we treat patients for 4 to 6 months. And if the patients have a good response, they can then start what we call a maintenance phase, which could be as simple as taking a tablet, capecitabine, and another option is to treat patients with a less intensive type of chemotherapy, for example, gemcitabine every other week, which I suspect the person in the question is referring to. There can be holidays, there can be stoppages in the chemotherapy for toxicity, but it's difficult to say, well, we're going to stop after so many months. Basically, it's an ongoing discussion between the patient and the doctor.
Great, thank you. That was a perfect answer and appreciate you explaining all of that. And all three of you, you talked about so many different wonderful types of treatments that are out there. So I thought this question was really relevant. The question is, what is the workflow to triage the patient for different treatment options? If anyone can kind of explain how that works.
Well, I'll begin by answering this. It really takes a full team. You've heard us mention the multidisciplinary team. Some of it depends on how the cancer is diagnosed. So a lot of times people will come into the ER with either they're jaundice, meaning they're yellow because there's a blockage of the bile duct, or maybe they have some vague abdominal pain, or something happens where it gets diagnosed. And then from there, depending on which teams are consulted in what order, usually what happens is you need to get proper imaging. You need to get imaging to make sure if there is metastasis, meaning spread outside of the pancreas, that you pick up on it. So that usually involves a CT scan and good imaging of the liver, which is we like to do with MRI. And the MRI also shows us what we need to know about the pancreas tumor itself. And from there, most commonly we proceed with a biopsy, and there's different options for that depending on the tumor. But more often than not, we see an endoscopic biopsy, which is the gastroenterologist will do. And then from there, we all get together and we reevaluate. Dr. Ukar had mentioned the different types of the classifications of cancer based on whether it's resectable, borderline resectable, or unresectable. And that will dictate a lot of times what we do first, second, third, etc. What I will say is more often than not now we're asking that patients get chemotherapy before surgery, except in very small tumors, just because it seems to have a good advantage, as Dr. Ukar mentioned.
Thank you so much.
Just to add a little bit to that, I would say that I'm very proud of the team that we have, because it's a team effort. It's a multidisciplinary approach to the management of pancreatic cancer. And I feel like we discuss all new pancreatic cancer patients prospectively. And among all the specialties, we decide what is the best approach for each particular case. So for some patients, it might be going directly to surgery. For others, chemotherapy or radiation therapy, followed by surgery, and so on.
And I even saw that collaboration, even putting this presentation together, the three of you, and starting with two of you and saying, we need more, we need to make sure and expand and cover absolutely everything. So that's very evident to me, and thank you for mentioning that. And then I wanted to ask a question that's probably for Dr. Chung. Can MRI-guided stereotactic ablative body radiation therapy be given to stage 4 patients?
So that's a great question. I would say in general, I mean, outside of, in general, in terms of cancer, patients who have limited metastatic disease, there's increasing data that in some of those patients, giving ablative radiation in addition to chemotherapy can improve clinical outcomes and potentially survival. The benefit among pancreas cancer patients is less well understood. There's some emerging data that in a certain population, there could be potential benefit, especially if the patient has had, stable or responding disease for a long period of time. And what a long period of time is pretty subjective, but, for patients, and I've treated patients who've had, metastatic disease, who are BRCA positive, for example, for a year or more, and there's only one metastasis in the liver. There's not randomized data that radiation improves outcomes there, but those are the types of scenarios where we might consider, local therapy.
Thank you. Wonderful. There are a couple questions by our wonderful survivor and caregiver chair in our Broward Palm Beach area. And he's a survivor, a 5-year survivor. Eric asked, are MRI scans also better than CT scans for long-term monitoring of potential recurrences? And his additional question that maybe someone can answer is also about when he had his surgery in 2017, he was just wondering, would laparoscopic have been an option at that time instead of his 4-inch incision? So 2-fold questions from Eric.
I guess I can address the MRI question, and maybe Dominic, if you want to take the other one. But MRI scans just inherently offer superior soft tissue image resolution, and it's basically you get a finer image of the soft tissue. So in general, getting MRI scans every single time is not necessarily beneficial to all patients, especially when we're looking at or considering surgery having the best picture possible to look at the, relationship between the blood vessels and the tumor. I think, and we prefer MRI here. Don't want to speak for Dr. Asman, but I mean, yeah, unless there's an MRI, basically, Dr. Asman is going to tell me we should get an MRI before these patients are assessed. And then, the MRI scans are beneficial in that way. For patients, however, in long-term follow-up, there's really not necessarily a need to get MRI scans every single time. CT scans are appropriate, but if there's a question that needs a little bit finer detail in terms of imaging, we might add an MRI scan onto the CT scans.
I agree with Dr. Chong. So a lot of surgeons and practitioners in general still don't use MRI as much as they do CT. This is due to the fact that MRI is more complicated to read and evaluate. Even some radiologists are not that comfortable with it. The MRI does give us better information about the soft tissue, about its relationship to the blood vessels, et cetera. And so once you're trained to evaluate the MRIs, we find them better. One of the advantages that we see with MRIs is that they tend to pick up on liver metastases more often than CT scans. The flip side of that, some people argue that the MRI might pick up things that aren't really metastasis, but it looks like it just because it's so sensitive to issues. But that being said, no, we definitely do prefer the MRI. It's important to, one, get the MRI done at a place that has a high quality MRI machine, has MRI technicians that know what they're doing, and make sure that it gets evaluated by physicians that are used to managing MRIs, because otherwise you can get misinformation if there isn't enough experience.
Great, thank you so much. And this is a little bit related, and we'll just have time for like maybe 2 more questions. But this one is pancreatic cancer only detected on a scan if the cancer has already metastasized, or can it be detected before it gets to that point?
So I'll just continue. Basically, no, most of the, not most of the time, very often we find cancers that have not metastasized. I mean, there's a high percentage of patients that do present with metastasis, but one of the easiest way to find a cancer in the pancreas, whether it's metastasized or not, is with a CT or an MRI scan.
Great, thank you so much. And the last 2 I'm going to ask, and I'm sorry we didn't get to everything, but we covered most of it. And I'll put my email on the slide at the end, but I want to give you all your time back. Got some busy doctors on the phone. So the question is, what is the status of early detection? Is there hope on the horizon so that more patients can have these minimally invasive surgeries and better quality of life?
Yeah, I would say that unfortunately, as Dr. Asbun showed in the cartoons when he was talking about surgical approaches to pancreatic cancer, the pancreas is an organ that is deep in the abdomen, is behind many structures, embedded in fat, and sometimes it's difficult to visualize it, actually, if you're not really looking for it, or if you don't have radiologists with experience in that area. So many of our patients present when it's a little advanced, when they already have symptoms, and ideally you would like to find the cancer at an earlier stage before it causes any symptoms whatsoever. So for patients with high risk because of familial history of pancreatic cancer, for example, or because of known mutations that increase the risk of pancreatic cancer, surveillance is usually with endoscopic ultrasound or with MRIs of the abdomen, focusing on the pancreas. And these are done as often as every 1 or 2 years. But there are new guidelines from the gastroenterological associations that are basically targeting early detection of pancreatic cancer.
Thank you so much. And we do have an early detection initiative that we're working on at PanCan. So if you want to learn more about that, you can go to pancan.org. And I know it's certainly a big topic of discussion and a really wonderful thing to, to fundraise for and to, continue to help our scientists and our doctors work towards early detection initiatives. And the last one I'm going to ask is, what can we continue to do as volunteers and advocates to support the work you are all doing and that can lead to new scientific discoveries?
mean, I guess I would start by saying, progress in any, in medicine in general, it comes from, generating clinical data and clinical studies and clinical trials. So certainly supporting state-of-the-art clinical trials, funding for those trials, support for those trials is critical to advancing our understanding of what is best for patients moving forward into developing novel technologies.
Wonderful. Anything else you two of you want to add about for our volunteers?
No, I just want to say, as much as we find that our team effort here, working with a lot of specialists and coming together every week, if not more often than that, to deal with patients is incredibly important. The support that patients get from their family members and their friends is also equally very important. They help us treat the patients that, we always say this is a marathon. It's not a short sprint. So it takes a lot of support to get someone through this treatment. And we very much appreciate anyone that's helping, as even peripherally, giving out information, et cetera. I want to make a quick comment because I see there are a lot of questions about survival, et cetera. If a patient is interested in knowing a specific survival for whatever stage they've been given it, you can Google and if you find the right sources, find numbers. But also it's important to remember that these are statistics and not everyone will fall within those numbers. And so the most important thing is to reach out to a center that has expertise, has experience, has people that are dedicated to treating pancreatic cancer and see what you can do to hopefully beat the odds. The numbers are not good at most stages of this disease, but at the same time, we as do other centers fight with everything that we've got to help people get beyond the curve.
And actually, if I can add something, Dominic, I think the other thing that I hear a lot is just lack of information among patients, knowing what's out there in terms of resources or treatments or whatnot. I've had so many patients tell me, well, the chemotherapy stopped working and I was told to go to hospice and these are patients from all over the country. And I didn't even know anything about, nanoknife or radiation therapy or advanced surgical techniques or whatever. And so that I think is the biggest thing, just sharing awareness about what is out there, and getting more knowledge about that can help obviously inform decisions. And so I think that's a huge thing.
Wonderful. Thank you. That was very well said. All of you, this felt like a 3 or 4 hours of information crammed into one. So it was just beautiful. And I have a couple things that I wanted to share about the Pancreatic Cancer Action Network. And you teed me up perfectly for it, Dr. Chung, before I let everybody go. All right. So first, I just wanted to remind everyone who does not know, about patient services at PanCan, something that we're always trying to get patients to be aware of. We, offer personal one-to-one support for patients and for caregivers, information about diet, nutrition, specialist searches, clinical trials information, and really exactly what Dr. Chung talked about, just always the most up-to-date, real, true information about pancreatic cancer. So it's a free service, and we hope that, there's the patient services email there and the phone number for those of you going through this yourselves or a loved one. And also we have our local volunteer affiliates. Many of these wonderful volunteers are on the call today, and we have a group in Miami and a group in Broward Palm Beach. So if you are interested in some helping out and volunteering year round, raising awareness funds, our event, advocating, please contact me at the bottom there. We would love to have you join our local PanCan groups. And then I wanted to remind everyone that next month is November Awareness. So this is a perfect time to learn about all of this and to get excited about all of the new approaches that are happening. And World Pancreatic Cancer Day is November 17th. So mark that in your calendars, wear your purple. I have 5 different things I wanted to just encourage everyone to do next month in November. So first, recruiting your Purple Stride team. Purple Stride is in April. I have a slide after this, but a great time in November to launch your team and to get everybody rallying around you to start your Purple Stride teams. Hosting a fundraiser, really great month to be able to do that. There's lots of fun fundraising ideas out there, and it would be great to get your family, friends, colleagues involved. Sharing your story. This is our wonderful Eric Gordon, our survivor. He had a beautiful story that he actually shared recently, and it was just amazing the awareness that he was able to spread and the love and support that came to him by just sharing a little bit about his experience and his 5-year survival. And then sharing PanCan's graphics in November. PanCan will be constantly sharing new graphics on Instagram and on Facebook, and certainly on our pancan.org website. So being able to share some of those different, there'll be statistics and infographics about signs and symptoms, and just general information that you can then steal and share to your own networks, and that can really go a long way. And lastly, I wanted to invite everyone to our November 17th World Pancreatic Cancer Day webinar. That will be a virtual webinar, and information will be coming out about that soon. You can check back on pancan.org about that webinar. And then PanCan Purple Stride. I'm not sure if any of the doctors on the phone will be able to join us. I know we're split up into 2 different places and you're busy, but we hope to maybe see a few of you. PanCan Purple Stride is going to be on April 29th this year. And the Broward Palm Beach event is going to be at Burt Aronson Park. That is the website that you can register at. And then Purple Stride Miami will be at Tropical Park again, and the website is there, and registration is free. So please invite anyone and everyone to join. And lastly, I just want to thank everyone on the phone. I want to thank Dr. Aspen, Dr. Chung, Dr. Ukar, and the community team at Miami Cancer Institute, Carla and Patty, and everyone behind the scenes, getting these wonderful specialists in front of us. And then for everyone who joined, our volunteers, our donors, our advocates, our patients, our caregivers, really just, this was a wonderful call. We had a lot of people on here, and I think we all learned a lot, and it got me really excited. So I hope it did for you too. There is my information, my contact information there at the bottom. And I will end it there and say, thank you, everyone. We hope to see you soon.
Thank you.
Thank you very much.
Thank you.